to nephritic syndrome, the hallmark of nephritic syndrome is glomerular inflammation and bleeding from the glomerulus. Now, these patients can have limited proteinuria. It's usually less than 3.5 grams per day. That helps to distinguish this from nephrotic syndrome. The patients can get oliguria, which is decrease in urine production, along with azotemia, which is an increase in nitrogenous waste products within the blood. There is some salt retention. The retention of salt will also result in the retention of fluid, which can then result in edema, particularly around the eyes. And that's because the minimal edema that develops particularly shows itself in the loose connective tissue around the eyes. In addition, because there's salt retention and fluid retention, the patients develop hypertension. Now, of course, I mentioned that a hallmark was glomerular bleeding, and one of the key signs of glomerular bleeding will be the presence of red blood cell casts. The idea here is that if this is the glomerulus, and the glomerulus is bleeding, so you've got red blood cells coming into the tubules, the red blood cells will get casted in the shape of the tubule, and then will be urinated out as this sort of square cast made up of red blood cells. And again, that's because it gets casted in the shape of the tubule. So red blood cell casts is a sign of glomerular bleeding. Now, if a biopsy were to be performed, we would see a hypercellular inflamed glomerulus. And remember that I told you that the hallmark was glomerular inflammation. Important to note that this inflammation is usually driven by the deposition of immune complexes. The immune complexes activate complement, and one of the byproducts of complement is C5a. Remember that C5a attracts neutrophils, and the neutrophils then mediate the damage, and that's why you get the hypercellularity in the glomerulus. Here's a glomerulus from a patient with nephritic syndrome, and we can see that there are way too many cells within the glomerulus, and in addition it's swollen and it's filling most of Bowman's space. The prototypic disorder that results in nephritic syndrome is called post-strep glomerulonephritis. Now, this is a nephritic syndrome that arises after a group A beta hemolytic strep infection of either the skin or the pharynx. In particular, it occurs with nephritogenic strains. So there are particular strains of group A beta hemolytic strep that carry a M protein virulence factor that increases the risk of the development of nephritic syndrome. And so again, it's important to note that the M protein virulence factor is what defines the nephritogenic strains. It's also important to note that you can get a nephritic syndrome after infection with non-strep organisms as well. However, prototypically, it occurs after a group A beta hemolytic strep infection. The classic presentation of PSGN occurs 2 to 3 weeks after infection. The patients present with hematuria, giving them a cola-colored urine, and they can also develop oliguria, hypertension, and periorbital edema, as I've already explained. Again, it's usually seen in children, but it can also occur in adults. On biopsy, you would see a hypercellular inflamed glomerulus. Again, this is mediated by immune complex deposition, so there would be a granular immunofluorescence. And one of the hallmarks of this disorder is that you have a subepithelial hump on electron microscopy. Here's a picture of the EM. This is a large subepithelial hump. Notice that it's sitting on top of the basement membrane, and this is where the epithelial cells would normally sit. Now, actually, what happens in this disorder is that the immune complexes actually start subendothelial, and then they slowly work their way up, and as they work their way up through this trilayer, they then pile up subepithelial. And eventually what's going to happen is this deposit will simply just dissipate into this space and disappear. And that helps me to remember that the treatment is actually supportive. You don't need to do anything. The deposits will simply just pass their way through and then disappear. Now, in most children, the disease will actually resolve, and they rarely progress to renal failure. However, adults do have a chance of progressing to renal failure, and one of the feared complications is something called rapidly progressive glomerulonephritis. Now, rapidly progressive glomerulonephritis is a nephritic syndrome that progresses to renal failure in weeks to months. When a patient comes in with rapidly progressive glomerulonephritis and they've got signs and symptoms of a nephritic syndrome and appear to be developing rapid renal failure, a biopsy will be performed. Now, the biopsy is characterized by crescents in Bowman's space, and it's very important to note for the purposes of board exams that the crescent is made up of fibrin and macrophages. Here's a picture of the glomerulus with the crescent. Now here I'm outlining for you the crescent, and so this represents the crescent. Here's the normal glomerulus. Now, examiners like you to know that this stuff here in the crescent actually is fibrin and macrophages, so it's inflammatory debris. And that's particularly high yield. It's not collagen, etc. It is macrophages and fibrin. Now, when a patient has rapidly progressive glomerulonephritis, the next thing that you're going to do after biopsy is immunofluorescence. And the immunofluorescence will help you, along with the clinical picture, to resolve the etiology. So there's three possibilities concerning the immunofluorescence. The first possibility is that you get something called a linear immunofluorescence. Now, the idea here is that you've got these endothelial cells, you've got a basement membrane, and then, of course, you've got your podocytes. If there is a linear immunofluorescence, then that means that you have an antibody against the glomerular basement membrane. This antibody then binds the glomerular basement membrane, creating a sharp line on immunofluorescence, which is called a linear immunofluorescence. Now, the key disease in which you see that is Goodpasture syndrome. Of course, in Goodpasture syndrome, you have an antibody against the collagen in both the glomerular and the alveolar basement membranes. And so these patients will present with hematuria due to the renal involvement, and they'll present with hemoptysis due to the pulmonary involvement. It classically arises in a young adult male. Now, another possibility would be to have a granular immunofluorescence. And you're well aware of the fact that when you have a granular immunofluorescence, you've got immune complex deposition. The most common cause, if there's a granular immunofluorescence, would be post-strep glomerulonephritis. And that's particularly important to note. Again, in PSGN, you've got antigen-antibody complexes which are depositing, which then cause the disease. Another very high-yield cause, if you had a granular immunofluorescence, would be something called diffuse proliferative glomerulonephritis. Now, in diffuse proliferative glomerulonephritis, you get deposition of antigen-antibody complexes that are subendothelial, underneath the endothelial cell. And what's very high yield to note here is that this is the most common type of renal disease that you would see in lupus. Remember that in lupus patients, the most common cause of death is renal failure, and that the most common disease that damages the kidney is diffuse proliferative glomerulonephritis, giving you a nephritic syndrome, and sometimes giving you a rapidly progressive glomerulonephritis. Now, it's also important to remember that if a patient with lupus presents with nephrotic syndrome, remember that the cause of nephrotic syndrome in lupus patients is going to be membranous nephropathy. Again, that's high yield as well. Now, finally, if you have a negative immunofluorescence, then they call that pauci-immune. Pauci-immune means limited immune, i.e. you really don't have anything significant on immunofluorescence. And so the next step in pauci-immune cases will be to perform something called an ANCA, anti-neutrophil cytoplasmic antibody. Let's go back and remind ourselves that when you perform the ANCA test, you have a slide with a neutrophil on it. Now, when you take the patient's serum and you introduce it to this slide, the antibodies in the patient's serum can either bind adjacent to the nucleus, or they can bind out here in the cytoplasm. If they bind adjacent to the nucleus, then that is called a perinuclear anti-neutrophil cytoplasmic antibody, or a p-ANCA. If they bind out here in the cytoplasm, then that is called a cytoplasmic anti-neutrophil cytoplasmic antibody. And of course, in a pauci-immune case, the ANCA becomes particularly important. The reason why is that patients who have a c-ANCA will have Wegener's granulomatosis. Now, in Wegener's granulomatosis, remember that you classically get involvement of the lung, giving you hemoptysis, and you also get involvement of the kidney, giving you rapidly progressive glomerulonephritis. But remember from our discussion of the vasculitides that Wegener's granulomatosis is that C disease. If you remember, I told you about the C mnemonic. And so it's not only going to involve the lung and the kidney, but it's also going to involve the nasopharynx. Now, this is very important for board examinations. When a patient comes in with hemoptysis and they come in with hematuria and they've got a rapidly progressive glomerulonephritis with crescents, the knee-jerk is to think that they have Goodpasture syndrome, because that's sort of the one that we classically remember. However, you need to be aware that if the patient also has nasal symptoms, nasopharyngeal symptoms like sinusitis, they could tell you, for example, on the exam that the patient also has a history of sinus infections or sinusitis, then you really need to think about the fact that you may be dealing with Wegener's granulomatosis, because sinusitis or sinus problems would not be seen in Goodpasture syndrome. And of course, the c-ANCA and the immunofluorescence would help to distinguish this, because you would have a linear immunofluorescence in Goodpastures, but you would have no immunofluorescence, but instead a c-ANCA in Wegener's granulomatosis. Now, if the patient has a p-ANCA, then there's two possibilities. One possibility would be microscopic polyangiitis, and the other possibility would be Churg-Strauss. Now, what's important to note is that in Churg-Strauss, you're going to have three things that you will not have in microscopic polyangiitis. Number one, you'll have granulomatous inflammation. That's not seen in microscopic polyangiitis, but is seen in Churg-Strauss. Number two, you'll have eosinophilia, which again would only be seen in Churg-Strauss. And number 3, you'll have asthma. And again, that would only be seen in Churg-Strauss. And so these are 3 important distinctions that you should note when you're trying to make the difference between Churg-Strauss and microscopic polyangiitis. Again, both giving you a P-ANCA. Here's the picture of the linear immunofluorescence. Notice that you've got immunofluorescence, but it contains these very sharp green lines. And so this would be an indication that you're most likely dealing with Goodpasture syndrome. Okay, moving on to IgA nephropathy. This is the most common cause of nephropathy worldwide. In this particular case, IgA immune complex deposits in the mesangium of the glomeruli. And so this is what it looks like. You get deposition in the mesangium, but the most important is that this is IgA, and so nothing else that we've covered would give you IgA deposition in the kidney. This is going to present during childhood with episodic gross or microscopic hematuria. You'll have RBC casts. Of course, if the glomerulus bleeds, then you're going to have casting of the RBCs, and it usually follows mucosal infections. Now, the idea here is when you get a mucosal infection, you end up producing excess IgA to try to defend yourself against that mucosal infection. So every time you get a mucosal infection, you produce a ton of IgA. Some of that IgA goes into the mesangium. It deposits as immune complexes within the mesangium, and then that's going to result in the glomerular bleeding. Now, of course, it's episodic because as the mucosal infection resolves, you decrease the IgA, and so the hematuria goes away. And then the next time you get a mucosal infection, you again get another episode of bleeding from the kidney. This can then slowly progress to renal failure. I've already mentioned the fact that you're going to have IgA immune complex deposition in the mesangium. Alport syndrome is an inherited defect in type 4 collagen. It's most commonly X-linked. And what happens here is that you get thinning and splitting of the glomerular basement membrane. Now, when that occurs, that's going to result in isolated hematuria. You're only going to have hematuria, but again, that's one of the hallmarks of nephritic syndrome. Now, the patients can also have sensory hearing loss because the basement membrane can be damaged in this region, along with ocular disturbances, also due to damage of the basement membrane. And so it's these 3 key findings, along with a family history, that clue you in to Alport syndrome: isolated hematuria, sensory hearing loss, and ocular disturbances in a family.